Hello everyone. So we will be doing chapter 16 of illustrated textbooks of pediatrics, which is allergy, features of allergic disorders in children. To 40% of children in the UK have one or more allergic disorders, eczema, allergy rhinitis, or asthma. 3% to 6% have food allergy. They have increased in prevalence in the UK. In many other countries, both high and low income. They cause significant morbidity and can be fatal. About 20 children or young people die from asthma and two from food anaphylaxis in the UK each year. An abnormal immune system may result in allergic diseases, immune deficiency, autoimmune disorders, either organic, type 1 diabetes mellitus, or systemic, that is SLE. Explanations of the terms used in allergy are listed. Mechanism of allergic disease. Many genes have been linked to development of allergic disease. Polymorphism mutation, these may lead to a susceptibility to allergy. Intact barrier function of the skin appears to be important. Alterations in the filaggrin gene are associated with increased risk of eczema and food allergy. Allergic diseases occur when individuals make an abnormal immune response to harmless environmental stimuli, usually proteins, and allergies, and epigenetic condition where the environment interacts with these genes. The developing immune system must be sensitized to an allergen before an allergic immune response develops. Only a few stimuli account for most allergic diseases. Inhalant allergens host dust, house dust mite, plant pollen, pet dander, and moles. Ingestion allergens are egg, cow's milk, nuts and wheat seeds, legumes, seafood and fruits, insect stings, bite, drugs, and natural rubber latex. Allergic immune response are classified as IgE mediated and non-IgE mediated. IgE mediated allergic reactions have a characteristic, characteristic clinical course, an early phase occurring within minutes of exposure to the allergen caused by reliefs of histamine and other mediators from muscles causes urticaria, angioedema, sneezing, vomiting, bronchoscopy, the shock. The late phase response will also occur after 4 to 6 hours, especially in reaction to inhalant allergens. This causes nasal congestion in the upper airway, cough, and bronchospasm in the lower airway. Potential late phase response to food allergy is why children need to be observed in hospital for several hours after moderate to severe food allergy reaction. The majority of severe life-threatening allergic reactions are IgE mediated. Non-IgE mediated allergic immune responses usually have a delayed onset of symptoms and more varied clinical courses. So, the allergic definition, hypersensitivity, objectively reproducible symptoms or signs following exposure to a defined stimulus, food, drug, pollen, at a dose that is usually tolerated by most people. Allergy, hypersensitivity reaction initiated to a specific immunological mechanism. This can be IgE mediated, peanut allergy, or non-IgE, that's celiac disease. Now, atopy, a person of familiar tendency to produce IgE antibodies respond to ordinary exposure to potential allergens, usually proteins strongly associated with asthma, allergic rhinitis, conjunctivitis, eczema, and food allergy. Anaphylaxis, a serious allergic reaction, bronchial, laryngeal, or cardiovascular involvement that is rapid, non-onset and may cause death. Immune tolerance, the absence of an active immune response against a particular antigen. Absence of allergic immune response to peanut or mouse dust mite is immune tolerance. And sensitization positive test to allergen either by skin prick test or specific IgE does not equate to allergy unless a clinical reaction is initiated and exposure. However, the higher the number of positive tests, the more likely the person is going to be allergic. Now, the uh, hygiene hypothesis is not clear whether the prevalence of allergic disease has increased in many countries. The speed of this change suggests an environmental cause. A consistent observation is that the risk is lower in younger children, large families, and in children raised on farms. These findings have led to the hygiene hypothesis, which proposes that increased prevalence is due to altered microbial exposure associated with modern living conditions. Although the hypothesis remains the leading explanation for the increase in allergic rhiinitis. It is mainly supported by indirect evidence. Clinical evaluation, allergy history, and examination. Allergy focus history is a cornerstone to correct diagnosis. The child and family may not volunteer a history of allergic disease as they have come to consider the symptoms as normal. Child who coughs most nights or has a blocked nose most of the time may not perceive this as abnormal. As allergic diseases are multi-system, in addition to signs of individual allergic disease, examinations may reveal mouth breathing. Children who virtually breathe with their mouth open may have an obstructed nasal airway from rhinitis, and there may also be a history of snoring or obstructive sleep apnea. An allergic salute from rubbing an itchy nose, from rubbing an itchy nose, pale and swollen inferior nasal turbinates from rhinitis, hyperinflated chest or head and sulci from chronic untreated asthma, atopic eczema affecting the lymph flexures, allergic conjunctivitis may be accompanied by prominent increase, many Morgan folds and pupil expression below the lower eyelids. Growth needs to be checked, especially in those with food allergy where dietary restrictions or malabsorption can lead to nutritional deficiency compromise, and in those treated with high dose inhaled nasal topical corticosteroid. Investigations are skin prick test. Skin prick test is a form of food and inhaled allergens and some used for investigating drug or insect sting allergies. A drop of allergen, either in an extract or the fresh food, is placed on the skin. The site is marked and the skin is pricked with a lancet. After 15 minutes, any wounds are measured to determine if positive. Providing antihistamines have been stopped 48 to 72 hours before testing negative to suggest that allergy is unlikely. Test results can also be interpreted in the context of detailed history. IgE blood test raised total IgE is an indication of A2P in child. For investigation, food or inhalation such as to milk, gas, pollens, specific IgE tests are required. Food that the child is already eating without symptoms should not be tested as it may yield a false positive results. The greater the response, the more likely the child is to be allergic. Negative result makes IgE-mediated allergy unlikely. Most recently developed competent blood tests to specific components of allergen can provide more specific information. Allergy facies is habitually open mouth due to mouth breathing, allergic salute, rubbing an itchy nose, and this is the skin prick test for IgE-mediated. Spirometry and other lung function may be performed to provide information on lung function diagnosis or monitor asthma or lung inflammation. Allergen challenge. If results from the history investigation are not clear, the child is thought to have grown out of an allergy. Allergen challenge may be performed. This is really food challenge for food allergy. The child is given increasing quantity of the food, starting with a tiny amount until the full portion is reached. Sometimes they are placebo controlled where the child and parents do not know which of the challenges involved. The food or placebo, the test should be performed in a hospital with full resuscitation facilities available with close monitoring for signs of anaphylaxis. Similarly, diagnosis are also sometimes performed. Organization of care, the individual diseases are managed by general practice practitioners, general pediatricians, or organ-specific specialists, eczema by dermatologists, asthma by respiratory pediatrician, how allergic diseases coexist, and it is therefore helpful to consider allergy as a systemic disease. The role of pediatric allergists is to identify trigger to avoid and to manage children with multi-system or severe disease. Management of cystic allergic disease and condition is described. As age of onset of allergic conditions, allergic children develop infectious allergic disorder at different age. Eczema food allergy usually develop in infancy. Allergic rhinitis, conjunctivitis, and asthma begin most often in preschool and primary school years. Allergic disorder often coexist. For example, most children with food allergy have a history of early onset eczema, and most children with asthma have some degree of allergic rhinitis. Prevention of allergic diseases. Many interventions have been tested for preventing allergic diseases, but only one has shown definitely reduced risk to allergy. date, this is the induction of immune tolerance by feeding common food allergens like peanut to young infants to reduce their risk of developing egg or peanut allergy. This is now often suggested in infant feeding guidelines for countries where food allergy is common, such as UK, US, and Australia. However, when multiple food allergens have been introduced together, the effect is limited due to difficulty feeding infants sufficient food allergens for long enough to prevent all food allergies. Thus, the impact of using immune tolerance to prevent food allergy is limited. Other approaches that tried without success include probiotic, live bacteria such as lactobacillus, prebiotics, non-digestible oligosaccharides, nutritional supplements, omega-3 fatty acids, vitamin D, antioxidants, trace elements, medications, antihistamines, immunotherapy, and skin moisturizers. There is some evidence how stress avoidance by covering mattresses may benefit some. Does sensitize children with asthma. Summary is pediatric allergy includes food allergy, eczema, allergic rhinitis, conjunctivitis, asthma, urticaria, and sixing. Hypersensitivity, drug allergy, and anaphylaxis occurs when a genetically susceptible person reacts abnormally to an environmental antigen. Different allergic diseases often coexist. If a child has one, look for others. Food allergy and food intolerance. Presentation varies between countries, cultures, with agents, and the child's age. And the most common causes are egg, cows, milk, nuts, and older children, peanuts, tree nut, fish, shellfish, and sesame. As food allergy is an allergy to the food protein, many other foods can be implicated, particularly in cultures and settings with diverse food intakes. Fruits, legumes, and seeds are also common causes of IG-mediated food allergies. Food allergy is most commonly primary, where children usually react on first exposure. It can also be secondary to cross-reactivity between proteins present in fresh fruits, vegetable nuts, and those present in pollens. A child who can eat apples may develop allergic to apples, but only if they become allergic to birch tree pollen because apple and bush pollen share a very similar protein. This common condition is called a pollen food allergen syndrome and generally leads to mild allergic reactions, often causing an itchy mouth, really systemic symptoms. Non-IG mediated food allergy typically occurs hour after ingestion and usually involves a GIT tract, and food allergy and intolerance are different from food aversions where the person refuses the food for psychological behavioral reasons. And food allergy occurs when the feature food allergy occurs when a pathological immune response is mounted against a specific food routine. It is usually IG mediated with a history of allergic symptoms varying from urticaria to facial swelling to anaphylaxis, usually 10 to 15 minutes up to 2 hours after ingestion of a food. Over 80% of food with food allergy present in the first year of life may have atopic eczema. A non-IG mediated food allergy typically occurs hours after ingestion and usually involves the GIT tract with diarrhea, vomiting, and bowel pain, and sometimes faltering throat. Sometimes presents in an infant with blood in the stool in the first few weeks of life from proctitis, or really with severe repetitive vomiting in infant following milk or rice, which can result in shock, food, protein-induced enterocolitis syndrome. Eosinophilic esophagitis presents with persistent vomiting, difficulty swallowing in young children and in older children with difficulty swallowing and impaction of food in the esophagus. A non-immunological hypocele reaction to specific food is called food intolerance. Example of each in relevance to relation to plasma is shown. The child history is key in food allergy diagnosis. Food allergy should be suspected if typical symptoms occur following exposure to a particular food. For IgE-mediated food allergy, the most helpful confirmatory tests are skin prick tests and measurement of specific IgE antibodies in blood. Management of food allergic child involves avoidance of the relevant food. This can be very difficult as the most common food allergens are common ingredients in the diet and may present in small quantities in many foods. Food labeling legislation requires all common food allergens to be clearly disclosed. Advice that a pediatric dietitian can help prohibitions avoid food to which they're allergic, find appropriate alternatives, and avoid nutritional deficiency. If a child is diagnosed with one allergy, related allergies need to be considered. 20% of children with egg allergy have peanut sensitization and may be peanut allergic, and children with peanut allergy will often have a tree nut allergy. Proteins with an unstable tertiary structure may be rendered non-allergenic by heat degradation or other forms of processing. For example, in milk and egg allergy, many children may be able to tolerate egg or milk in a baked form with a change in protein epitope brought about by cooking at high temperatures makes the food less allergenic. So some children are allergic to runny egg but can tolerate eating cooked egg or egg in baked foods. In addition to dietary management, the children and family must be able to manage an allergic reaction, written self-management plans, and adequate training should be provided. Mild reaction rates, swelling on lips and eyes and face are treated with non-sedating antihistamines. Severe reaction with cardiovascular, gingival, or bronchial involvement are treated with an adrenaline given intramuscularly by auto-injector EpiPen, which child or parent should carry with them at all times. Immunotherapy for food allergy involves giving the child minute amounts of the food they're allergic to and building up that amount over time. This is substantial risk of significant allergic reaction during this treatment is highly resource intensive. The Food and Drug FDA in the US has approved the product for peanut milk, but is not recommended in the UK. Although it increases threshold reactivity, it also increases risk of allergic reaction and anaphylaxis. It is unclear whether food allergy immunotherapy has a positive effect on quality of life. Food allergy to cow's milk and eggs often resolve in early childhood, and gradual reintroduction under supervision of a pediatric dietitian will be possible for these foods. Food allergy to nuts and seafood usually persists throughout their adulthood. Diagnosis of food allergy should not be made lightly. Dietary restriction or fear of genetic reaction make a major impact on family life. Example of food allergy: hypersensitivity to milk, IG-mediated food allergy, immediate calmness allergy. Clinical features: acute allergic reaction are listed. 6-month-old breastfed infant develop visceral urticaria immediately after first formula feed. Skin prick test was strongly positive 8 mmV to cow's milk, confirming the diagnosis of IG-mediated cow's milk allergy, visceral urticaria, lip swelling after milk restriction shown in BN. See clinical features of an acute allergic reaction, mild reaction, urticaria, and itchy skin, facial swelling, severe reaction, wheeze, strident, tongue, pain, vomiting, diarrhea, shock, and collapse. Non-ID mediated garment that give form of the formula effects since birth has loose stools and following grade. Skin protective colors are negative, 0. Elimination of cause which results in severe symptoms, which result on trial. Trial reintroduction. Non-allergic foods have a sensitivity, temporary lactose intolerance. Previously, well, 12 month infant develops diarrhea, vomiting, normally settles stool, watery stool, continue for several weeks. Stool sample, no vaccine was positive for reducing substances. Diagnosis: temporary lactose intolerance following viral gastroenteritis. Now, somebody's food allergy affects up to 6% of children. Most common causes are egg, milk, nuts, seafood, wheat, legumes, seeds, and fruits. Diagnosis of IG-mediated allergy is based on suggestive history supported by skin prick tests on specific IgE antibodies and blood supervised through challenges sometimes necessary to clarify the diagnosis. Those at risk of severe infection with previous anaphylaxis or coexistent asthma should carry insulin. Auto-injecting eczema can be either atopic, where there is evidence of IgE antibodies to common allergens, or non-atopic. Atopic eczema is classified as an allergic disease as many affected children have a family history of allergy. At least 80% develop other allergic diseases and IgE antibodies to common allergens are usually present. Filamin gene mutations have been identified as a key genetic risk factor for eczema development due to impairment of skin barrier function leads to cutaneous sensitization to Indian and to food allergen. This means that filamin gene mutation predisposed to food allergy, asthma, and hay fever as well as eczema. Up to 40% of young infants with severe eczema have an IG-mediated food allergy. Eczema is considered further Allergic rhinitis, conjunctivitis, rhinoconjunctivitis. This can also be atopic, associated with IgE antibodies to common inhaled agents or non-atopic. Rhinoconjunctivitis is classified according to the pattern and severity of symptoms experienced. Therefore, it may be intermittent, persistent, and mild, moderate, or severe. In temperate climates, it is often classified as seasonal, related to seasonal grass, weed, or tree. Pollens and perennial, related to perennial allergens. Sorry, related to perennial allergens, the house dust mites or pets. It affects up to 20% children, severely disrupt their life. In addition to its classic presentation, coryza and conjunctivitis can also present as caffeine rhinitis due to a postnatal drip, or as a chronically blocked nose causing sleep disturbance with impaired daytime behavior and concentration. Allergic rhinitis and its association social eczema, sinusitis, and adenoidal hypertrophy and explosive social asthma. Initial treatment is shown in the box. Children who remain symptomatic may be given specific allergen immunotherapy, which can be highly effective. Solutions where agents are injected subcutaneously or administered sublingually regularly over several years. To develop immune tolerance, subcutaneous immunotherapy must be carried out under specialist supervision due to the risk of anaphylaxis. Sublingual immunotherapy is usually initial choice as it is safer. Range of treatment for allergic rhinitis and allergen avoidance. Nasal saline inhalation tolerated. Second generation non-saline antibiotics. Nasal inhaled corticosteroids ensure adequate technique. Eye drops, chromoguidate or else steroids and rough ophthalmology supervision, leukotriene receptor antagonist, metallocast, and allergen immunotherapy. Allergy is an important component of asthma. Affected children often have IgE antibody to arrow allergens, house dust mite, tree grass, and weed pollen, moles, animal danders. Arrow allergen avoidance is difficult to achieve, but ways to reduce exposure to house dust mite in the home may be helpful. For those who also have food allergy, uncontrolled asthma is a risk factor for severe and even fatal food allergy reactions. Urticaria and angioedema. Urticaria presents as hives or redness and results in local vasodilation, increased permeability of capillaries and vanules. These changes are dependent on activation of skin mast cells, which release a range of mediators, including histamines. It is itchy urticaria and for deeper tissues, reduced swelling and angioedema, especially for the lips and soft tissues around the eyes, while hives and angioedema can be symptom of IgE-mediated allergic reaction. Not all hives are due to allergy. Hives and angioedema due to IgE-mediated allergy will occur very shortly after exposure to potential allergen. Less than 1 hour are reproducible. That is, they happen whenever the child is exposed to allergen and resolve within 2 to 4 hours of allergen removal. Acute urticaria can also occur from after viral infection. Rash usually lasts for days rather than hours. Chronic urticaria persisting more than 6 weeks is usually non-allergic. Treatments for second generation non-sedating antihistamines if the need to be increased up to 4 times the standard dose. In refractory cases, anti-IgE antibody omalizumab may be used. Angioedema without urticaria is a feature of C1 esterase inhibitor deficiency, which results in hereditary angioedema. This very rare condition is due to an inability to control the complement cascade. This needs specialist review. Drug allergy. Drug allergies occur in children but are not common or the minority. While labeled drug allergic are truly allergic, usually label of drug allergy arises because of viral illness for which the child has been prescribed antibiotics for the skin rash. Detailed histories regarding the nature and time of the rash in addition to taking the antibiotics. Any mucous membrane, widespread skin or systemic involvement may suggest a more severe drug allergy, such as Steven-Johnson syndrome or drug rash with xenophobia and systemic symptoms. And allergy skin and blood tests may be used to support a diagnosis of drug allergy. A drug challenge may be the only way to conclusively confirm or refute diagnosis. Uh, the diagnosis. Drug challenge is not safe after a severe drug reaction, and alternative drugs should be sought instead of re-exposing the patient to the same drug. True vaccine allergy in pregnant children is rare. When present, it may be caused by gelatin later antibiotics in the vaccine. There is often concern about the vaccines to children with food allergy. However, multiple studies have shown that egg allergic children can safely have mRNA through vaccines due to negligible egg protein content. Yellow fever vaccine does have a quantifiable level of egg protein. If required in an egg allergic children, it should be given in hospital. Vaccine do not cause allergies. Insect skin hepatitis in UK arises. This arises mainly from bee and wasp stings. The allergy reaction may be local, cutaneous, post-reactive, systemic, severe systemic reaction, and radiant channel. Children with a local reaction, even if large or mild systemic skin reaction, are unlikely to develop severe reaction in the future, and the family can be reassured. Those who had a severe systemic reaction or have significant anxiety about a further reaction should be offered an adrenaline autoinjection. This may wish to consider allergy immunotherapy, especially if the risk of resting is high or if the fear of resting has a big impact on the child's quality of life. Now, anaphylaxis, immediate management of serious allergy like fleeting allergy reaction is prescribed in children. The most common cause of anaphylaxis is food allergy, but can also be used by insect stings, drugs, and may even be idiopathic. Those at risk of anaphylaxis should carry an auto-injection device on the person at all and is considered a Medi-Alert bracelet or necklace. Some organizations recommend carrying two adrenaline in case one misfires or further door is needed. So this is all for the allergy section. Thank you very much.